Good evening, everybody. Welcome to the ICA webinar number 218. And as I've always tell in my webinars in the introductory remarks that these are the only webinars that have been conducted consecutively every Wednesday since the last 4 years. And I'm truly proud of the teamwork that is being played and that we have been managing to do this successfully. Another good news that I need to give you is that we have just concluded our 5th national and 15th national and the 5th international conference of the Indian College of Anesthesiologists in Lucknow, which was just concluded Sunday, that is today is Wednesday, just 2 days back. It was a very successful conference and we had about 700 registrations. The first day was for paramedics workshop, then the workshop for the doctors, and then 2 very, very exciting days of the conference. And all the credit goes to Dr. Monica Kohli and her team, Tanmay Tiwari, and all the rest of the KG Medical College. We also released the Yearbook of Anesthesiology, volume 14, and these books are also very, very popular with the students and the faculty. And today I'm very happy that we are hosting the Neuroanesthesia webinar today. And the topic is Posterior Fossa surgery. And for this, our moderators are 2 very senior faculty and very, very popular. Dr. Monica Tandon, she's Director Professor and the Head of the Department at the Department of Neuroanesthesia in the GB Pant Hospital. And Dr. Bhuwan Panday, Senior Consultant in the Department of Anesthesia in my hospital, the Sir Ganga Ram Hospital, New Delhi. So Monica, I request you to please start the moderation, introduce our speakers who will be speaking on 2 very, very important topics. Thanks a lot.
Thank you so much, ma'am, and thanks for inviting us for this webinar. It's always an honor and a pleasure to be associated with you. You're such a visionary that, any kind of association really rubs back on us, and that excitement, you have this tendency to kind of put a spark in all of us. And the topic that you've chosen today for the webinar is an extremely important one, because this is an area that is very, very challenging, both for the neurosurgeon as well as the neuroanesthetist. Posterior fossa is, it occupies just around 5% of the entire brain area. But all the critical vital structures are packed out here in a very, very small space. And one small amount of bleed or small amount of edema can have really, really catastrophic consequences. Sometimes I kind of wonder, because I'm kind of so close to Old Delhi, this reminds me of the Chandni Chowk lanes, where all the trade of Delhi happens through Chandni Chowk, and one small event and it can, really blow out everything else. So we've got to give a lot of respect to the posterior fossa. We have 2 sessions today. There are 2 talks on posterior fossa. The first one is on anesthesia management for posterior fossa surgery. And this is by a very, very bright young neuroanesthetist, Dr. Sagar Debbarman. Dr. Sagar Debbarman is an alumnus of All India Institute of Medical Sciences. He did his DM in neuroanesthesia from there, and he's now with us as an assistant professor. And very, very bright young boy on the horizon. Welcome, Dr. Sagar.
Thank you, ma'am. Thank you very much. Thank you very much. Good evening, esteemed faculties, respected moderators, and all the participants. So, as ma'am told, we are going to present today the posterior fossa surgery related thing. I'm going to share the screen right now. Okay. So today the topic we are going to cover is anesthesia management of posterior fossa surgery. Here a brief of relevant anatomy about the posterior fossa. As we know, it's a deep fossa and a non-compliant one, and it's divided by tentorium cerebelli, that is below the tentorium cerebelli. We call it also as infratentorial fossa. So it is surrounded by anteriorly by clivus and dorsum celli, and laterally by petrosal part of the temporal bone, posterior inferiorly by occipital bone, and the roof is formed by tentorium cerebelli. So some important structures are present in posterior fossa, like cerebellum, midbrain, pons, medulla, dural sinuses, fourth ventricle, cerebral aqueduct, and cranial nerves like 3rd to 12th cranial nerves. So why this anatomy is important for us to know? As we know, it's a small vital space with limited compensatory latitude, and it contains all the vital centers of our body, like respiratory centers, cardiorespiratory centers, then cranial nerve nuclei, then ascending and descending tracts. So any pathology involving these pathways or these centers can lead to catastrophic consequences. So what lesions we can see in posterior fossa? In pediatric patients, 50 to 70% tumors arises from posterior fossa only, and posterior fossa also account for 15% of the aneurysm. The lesions which we see can be vascular or can be neoplastic, can be a tumor like vestibular schwannoma or meningioma or epidermal tumor, can be abbey malformations, can be a cyst, or can involve the cranial nerves like trigeminal neuralgia or hemifacial spasm, etc. So, before proceeding to anesthetic management, what are the common surgeries we day to day we encounter in posterior fossa? Like there are different approaches. The common ones are midline suboccipital craniotomies, retromastoid suboccipital craniotomies, that is RMSOC, and subtemporal craniotomies. Other than that, there are translabyrinthine approach and midline approach. Many are there. So, how the patient present in a presentation of a posterior fossa tumor, it depends upon the anatomic location of the lesion, also the type of the lesion. Normal presentations are maybe as a asymmetrical hearing loss or tinnitus or vestibular dysfunction. Patient may have cranial nerve palsies, and with the lower cranial nerve involvement, patient may have bulbar palsies, may have ataxia, and another important thing is hydrocephalus, and patient may also present in emergency department as a signs of raised ICP with nausea, vomiting, headache. Seizures are less common in posterior fossa in comparison to supratentorial lesions, but still it may be present as a seizure also. So in examination, what we can get in examination, we can get seventh cranial nerve involvements, like seventh, eighth cranial nerves may be there, or maybe that we can give, check for the eighth cranial nerve, like Weber test, niche test can be done, or maybe cerebellar signs may be present. So these are the common tests we use in our clinical practice to determine this involvement of cranial nerves. Like eighth cranial nerve, we go for Weber test and Rennie's test, and for gag reflex and cuff reflex, we daily to daily we used to do. Then Romberg test to rule out any cerebellar deficit or any sensory ataxia. So how to confirm the diagnosis? We'll go for an MRI to look for the lesion. We can also go for NCCT initially to look for any bleeding or any bony involvement. So here we can see in the imaging there's a lesion arising from the left CP angle. So it's mostly a vestibular schwannoma arising from the posterior fossa. So what are the major anesthetic concerns for us in a posterior fossa surgery? There are potential for the brainstem injury. There may be acute hydrocephalus with acute rise of intracranial hypertension. There may be hemodynamic disturbances due to the surgical procedure or due to the positions. And there may be complication related to different positions of the surgery. So in pathophysiology of these two important features, like acute intracranial hypertension and acute obstructive hydrocephalus, as we know, it's a very small limited place, so there's a compensatory mechanism is not working here. So even a small amount of any lesion like bleeding or edema can give rise to massive rush to ICP. Furthermore, there may be obstruction of the fourth ventricle or cerebral aqueduct. So these will give rise to acute obstructive hydrocephalus. All these leads to brainstem compression, herniation, and then subsequently it will depress the respiratory centers and cause respiratory arrest and cardiovascular collapse. So in pre-anesthetic evaluation, apart from the routine pre-anesthetic evaluation, what we do in normal neurosurgical cases, here we should give emphasis in optimizing the coexisting medical conditions. Also, the patient may present with raised ICP, so there may be dehydration and electrolyte disturbances, which should be optimized and correct before proceeding for anesthesia and surgery. Patient may present with cranial nerve dysfunction. There may be loss of cough reflex and gag reflex, and patient may present with aspiration pneumonitis. And for that, we need to counsel the patient relatives also, and about the need of postoperative ventilation, and even tracheostomy. Also, the patient may present with vision or auditory functions. And we should also communicate with the neurosurgeons about the positions they want to choose for this patient beforehand, so that we can prepare and proceed accordingly. So about positions, what positions we can use here? We can go for sitting, prone, park bench, lateral, three-quarter prone, even supine position also. Though it's rarely used nowadays because it will cause much more head turn and head rotation, which will hamper further the venous drainage and will cause further rise in ICP. And it's a very difficult access, so it's avoided nowadays. Whatever the position is, we have to take care about the dislodgement of the ET tube, and we have to take care all the pressure points, and we have to take care of the peripheral nerve also. So here a picture of sitting position, how it is done. So I'll describe it later, subsequent slides. So why surgeons want these sitting positions? That is why, because it causes excellent operating condition because of gravitational drainage of the blood and CSF, so that operation field get clear and there's excellent operating condition. Also, optimum surgical access will be there. There's a less chance of retraction injuries, reduced bleeding, as it has been probed in different studies, and also better cranial nerve preservations. What are the disadvantages for the surgeon? There's increased incidence of postoperative and intraoperative complications. So for anesthesiologist, what are the advantages? For us, it will be a better airway access in sitting position, better ventilation parameters, airway pressures are on lower side, and in case of any cardiovascular collapse, it's easier to do CPR. And for us, the disadvantages are hemodynamic instabilities, increased incidence of VAE, increased incidence of complications like macroglossia. It will hamper the extubation process also. So, is there any contraindication for sitting position? Yes, there's one absolute contraindication is patent ventriculoatrial shunt, and another is if there is a signs of severe cerebral ischemias. There are some relative contraindication also, like right to left intracardiac shunts. If there is a cervical spinal instability, cervical canal stenosis, if the patient is not hemodynamically stable, if there are anesthesia team is not familiar with the position, extreme of ages, and if there is severe autonomic neuropathies. So, what are the complications? In complications, there may be hemodynamic instabilities, venous air embolism, and paradoxical air embolism are the two dreaded complications of sitting position. Tension pneumocophalas is another one. There may be mid-cervical quadriplegia. There may be edema to the face and airway and macroglossia, and compressive neuropathies and pressure point source may be present. So why there is hemodynamic instability in sitting position? First of all, patient is anesthetized, so there is anesthetic effect causes vasodilation and myocardial depression. Furthermore, in sitting position, there is pulling of the blood in the lower extremities, so it will decrease the cardiac index, the blood pressure, concomitantly give rise to increase in systemic vascular resistance. Ultimately, all these leads to compromised cerebral perfusion pressure. To prevent it, we can use the modified sitting position or semi-sitting position, and we can keep the hips and knees flex, and knees should be kept at the level of the heart. Now, in sitting position, it should be reach within assumed and reach around 10 minutes, and adequate preloading of the fluids like 20 ml per kg of crystalloid or colloids can be given. Intermittent compression stocking should be applied in the lower limbs to prevent hypotension. So how to achieve this sitting position? Here is a picture of sitting position. Here the patient is anesthetized in a supine position first. Then the back end is elevated slowly, gradually over 10 minutes. And it's kept around 45 to 60 degree. In modified position, we can keep the bed at the Trendelenburg position and the back end is then elevated. The lower extremities should be kept inside the table. It should not be hanging, and all the legs should rest in pillows. All the body prominence should be padded well. Now, elbows should be supported to avoid any brachial plexus stretch. Now legs to be positioned. Now the cushion should be placed inside the knees so that it will prevent any common peroneal nerve injuries. And the flexion of the knees and the hip to the chest should not be more than 90 degree, because it will further hamper the venous return and then it will cause lower limb ischemias. Another important point is gap between the chin and the sternal notch. It should be around 2.5 centimeter or 2 finger breadth. It should be more than that, so that it will prevent the excessive flexion should be prevented. We can put a bite block instead of a large airway, and extreme rotation of the head should also be avoided. As we know, the extreme of edges are relative contraindication, but there is a study by E.A. Harrison. It has shown that they have done it's the largest study in sitting position for children. They have shown that a median age from 6 weeks to 17 years, they have done sitting positions where complications like venous air embolism occurred, but it gets relieved promptly with the no preoperative morbidity or mortality. So they have concluded that that sitting position can be applied to children and is safer in neurosurgery for neurosurgery. So a bit about other positions like lateral positions. Nowadays it's preferred. It's because of improved surgical access and better hemodynamic stability with less incidence of VAE. But there are issues like axillary artery compression, brachial plexus injuries, ventilation perfusion mismatches, and the dependent lug. And axillary role must be placed in the chest to prevent the brachial plexus injuries. And the marred flexion of the extremities should be avoided. This is a prone position. This is also done in case of midline tumors, in case of, especially in case of children having medulloblastomas. There's a low incidence of VAE and but with the hypotension, but there's a chances of blood loss more than sitting position. Disadvantage include restricted airway access, difficulty in doing CPR, post-operative visual loss, intra-abdominal compression will further give rise to raised ICP, and extreme neck flexion can cause macroglossia and cervical spinal cord compressions. These are the other positions. That is a 3/4 prone is a modified of lateral position only, and another is park bench position. Nowadays is preferred by neurosurgeons for park bench position because of better surgical access. Here the body you can see it will the trunk is around 15 degree extended from the lateral position with the hand hanging outside the OR. It is well supported. So these are new positions are now preferred by neurosurgeons other than sitting position. So so after positions, how we'll proceed for the case? For induction, the goal of induction are to avoid any hypotension, hypoxia, or hypercapnia. That is maintenance of CPP and avoid any further rise in ICP. Common induction agents can be used like propofol, thiopentone, opioids like fentanyl, remifentanil, or a muscle relaxant. Now, an additional dose of anesthetics can be given before laryngoscopy, or Zylocard or any beta blockers can be used to blunt the hypertensive response, which is important in this case. For endotracheal tube, we can use reinforced ETT, though PVC ETTs can also be used in such cases, but reinforced is preferred. Then, as I already mentioned, a gap of 2 fingers should be there between chin and the sternum, and normocarbia is maintained. For maintenance, there is always controversy whether to use TIVA or balance anesthesia. Now, it totally depends upon the condition of the patient, and the condition depends on the ICP of the patient, amount of the brain relaxation required, and if there is intraoperative neuromonitoring is facilitating. Another controversy is whether we like to use nitrous oxide for this posterior fossa or not. It's always controversial. Now, nitrous oxide normally in supratentorial lesion, it has been used and seen for better hemodynamic stabilities, but it also has deleterious effect like rise in ICP, expansion of gases, and can increase the venous emboli. It can cause postoperative nausea, vomiting. It has been seen that nitrous oxide was avoided previously for VAE to prevent VAE, but it has been shown also that VAE can happen without using nitrous oxide also. But a vigilant monitoring is what needed, because if VAE happens, then we have to stop nitrous oxide immediately. Another controversy is pneumocephalus. Now, it has been Nitrous oxide has been implicated as a positive factor for pneumocephalus, but pneumocephalus can even happen without using nitrous oxide. Many studies are there, so it's always controversial. But theoretically, it has potential to change a pneumocephalus into a tension pneumocephalus one. So it depends on the discretion of the anesthesiologist whether to use it or not. So in monitoring, the routine ASA monitor should be attached. Apart from that, another important is invasive blood pressure monitoring, which is a must in such cases. And the transducer is zeroed at the level of external auditory meters. Central line is also required for CBP monitoring, for inotropic support if required, and also for respiration of air in case of VAE happens. Neurological monitoring, it will be discussed later in this class only. So while doing surgery intraoperatively, there may be hemodynamic instability. The causes may be because of manipulation of lower pons or upper medulla, maybe because of trigeminal reflex, maybe because of bleeding or VAE or position related changes. If these hemodynamic changes occur, suppose bradycardia occurs intraoperatively while handling the brainstem, the first thing we need to do is to inform the surgeon first. Uh, Most of the time, if you remove the offending stimulus, it will resolve automatically. So we'll defer giving any long-acting drugs like atropine. It will further mask the conditions of brainstem handling. It will further mask the condition like bradycardia. So better to avoid it until and unless it's absolutely necessary. Now another dreaded complication is venous air embolism. Now it refers to entrapment of air from an open vein into systemic circulation. It can occur in any position where the site of the surgery is above the level of the heart, and most common is neurosurgeries. But the incidence is around 7 to 76% in sitting position, whereas in horizontal position it's around 1.4 to 12%. How does it occur? Because of the negative gradient, the non-collapsible veins are present, and the subatmospheric pressure, it causes entrapment of the air. Which veins are offending veins like cerebral venous sinuses, emissary veins, and diploic veins. So once it get entrapped, it will travel through the venous sinuses to the jugular vein and through atrium and the right ventricle and enter the pulmonary circulation. If it enters the systemic circulation, it will cause paradoxical air embolism. So the features which can get after VAE depends upon the amount of the air, the rate of the air and entrapped. But these are the common symptoms like mechanical obstruction, local hypoxia, bronchoconstriction, and paradoxical air embolisms. So are all VAs are relevant? Most of the detective VAs are clinically not relevant. So we don't have to worry about all VAs. It depends upon the volume of the air entered and rate of the air entered. The lethal dose is around 3 to 4 ml per kg in adult patients. 100 ml of the air in the inside the veins, the symptoms of hemodynamic changes starts. So these are the signs, vital signs. It will come as a later in later stages mostly. There's a fall in BP or drop in SpO2 and ECG changes, airway pressure. If we do ABG, it will show respiratory acidosis with hypercarbia. In the massive air embolism at the last stages, we will hear the Millville murmur, this is classic murmur for venous air embolism. Now, it depending upon the amount of the air, it can divide into the acute and small. There's a fall in ETCO2 and desaturation. Acute and medium, there may be ECG changes. In awake patient, it will cause wheeze, bronchoconstriction. Then cerebral and myocardial ischemia may happen. And the large embolism may cause complete cardiovascular failure. So in large embolism, it will directly cause mechanical obstruction and give rise to right ventricular outflow obstruction and causes this cardiovascular collapse. So there's a fall in ETCO2 always in when VAE happens. It's a semi-quantitative method to measure the VAE. Why there's a fall in ETCO2? Because these microbubbles travel into pulmonary vascular circulation and it will cause increase in pulmonary vascular resistance, which causes increase in physiological dead space, VQ mismatch. Because of that, there is a fall in ETCO2 with a concomitant rise in PaCO2. A few words about paradoxical embolism. Now, one patent foramen ovale, it's present in around 20% adults. So, air may embolize through right atrium. It may goes into systemic circulation and causes paradoxical air embolism. But PAE can occur in absence of any septal defect also. Any large embolus can go through any intracardiac shunt and goes to systemic embolization. It will cause further coronary and cerebral vessel ischemia and leads to complete cardiovascular collapse. So, what are the modalities we can use intraoperatively to detect the VAE? This is a transesophageal echocardiography. This is the most sensitive one and is the gold standard one. Normally, mid-esophageal four-chamber view or bicable view is used, and it's a highly sensitive. Sometimes it will unnecessarily detect a small amount of the air as a VAE also, and it requires expertise. It may causes macroglossia also, and it's very expensive. Another is precordial Doppler. It is also most sensitive non-invasive monitor to detect VAE. But is sometimes the probe is difficult to place in obese patient and during lateral position. Others like ETCO2, it's a semi-quantitative method. When there is a sustained and a sudden drop of ETCO2 by 3 to 5 millimeter of mercury without change in minute ventilation, we can suspect VAE. But it is non-specific. It may happen in hypotension and it's not reliable in COPD patients or if there is any other hypotensive episodes. Other changes like ECG and esophageal stethoscope, these will come later. Another is ETN2. This is specific for VAE when nitrous oxide is not used as a carrier gas, but this is very not widely available and not reliable also. So here you can see the picture of a VAE through the view through a transesophageal echocardiography. There's a GIF image also. You can see the air bubbles are crossing through the ventricles. So this is how a VAE looks like in transesophageal echocardiography. Now, if VAE happens, then what are our goals of management? We need to prevent further entry, we need to give supportive management, and we need to reduce the volume of the air. So, for further entry, we immediately notify the surgeon. Surgeon will flood the surgical field with saline, and he will try to close any bleeding, any offenders with gel foam or cautery or any other thing. And surgical site, if possible, should be lower than the level of the heart and kept in internal position. And we should discontinue nitrous oxide if it's going. 100% oxygen should be given, and then aspiration of the air from the right atrial catheter. To maintain the hemodynamics, IV fluids, inotropes, and antiarrhythmetics as required. Is the role of jugular venous pressure? Now, historically, the jugular venous pressure had role, but it will further undo causes increased rise in ICP and decrease the CBF. On bilateral pressure can cause severe bradycardia also, venous engorgement. So it is not used nowadays. And for cardiovascular collapse, CPR should be initiated as soon as possible. And, cardiac message also can break down the large emboli and disrupt a large airlock in the right ventricle. In postoperative period, supportive methods along with hyperbaric oxygen therapy can be given. Now, for aspiration of the right atrial catheter, the only proven treatment for VAE. So large diameter catheters are always and multi-orifice catheters are preferred. What are the optimal position? The multi-orifice catheter should be placed 2 centimeter below the junction of SVC and right atrium. For single orifice catheter, it should be placed 3 centimeter above the junction of SVC and right atrium. Now, how to confirm that? We need to confirm it through chest X-ray, by dynamic X-rays. We can put intravascular ECG by showing the biphasic P wave, or we can use a transesophageal echocardiography to confirm the position. So, prevention and the vigilant monitoring are the main thing for VAE. Now, how to prevent it? We can prevent it by alternative positions such as park bend or prone positions. Tenderloin position can be used while inserting or removing CVC, prevent hypovolemia by adequate preloading, and weak intermittent stocking should be put the patients. Now regarding PFO, do we need to screen all patients for PFO? In our setup, in Indian setup, we are not doing that. Even it's not recommended also, because it is screened using transthoracic or transesophageal bubble test or TCT or CT or MRI. So the false negative results are very high with transthoracic echocardiography, and it has been shown that PAE can occur in absence of septal defect. So it's not widely practiced. There's one systemic review, and it has given a flow chart that how to proceed if you're planning for the PFO screening. Then in a preoperative, they have advised a preoperative TE in a sitting position. If the surgery is there's no PFO detected, then we go for sitting position. If the PFO is detected, then we should wait for that for 2 to 4 weeks. So postoperative complications are respiratory compromise because of brainstem handling, intraoperatively pain, postoperative nausea, vomiting, compressive myelopathies, postoperative visual loss, macroglosia, mid-cervical quadriplegia, and persistent postoperative hypertension may be present because of brainstem compression, pneumocephalus, and posterior fossa syndrome may be also present in children. So this is a NCCT head showing this is tension pneumocephalus showing Mount Fuji sign. These are the peaking of the frontal lobes, and this is the signs of called Mount Fuji sign. So pneumocephalus is another complication. It occurs 100% in patient with sitting position and 72% in park bench position. But usually it is asymptomatic and get resolved in 2 to 3 weeks. If there is a tension pneumocephalus, which is a dreaded complication, there will be delayed recovery, there will be neurological deficit with brain herniation, and it's always an emergency. So how to treat? We need to put the patient 30-degree up, avoid any ICP raising maneuvers like coughing, straining, or pain. Any augmented normobaric or hyperbaric oxygen should be given. And in case of emergency, we need to drain the air using twist drill bar hole surgeries. So emergence and extubation, what are the anesthetic goals? Now we need to prevent any abrupt blood pressure. It should be smooth and rapid extubation after neurological examination. Minimum coughing and straining. Prevent any postoperative pain, nausea, or vomiting. What are the factors which may affect the emergence in posterior fossa surgeries? Are the extensive brainstem handling, intraoperative brainstem handling. We normally electively ventilate the patient. If the preoperative GCS is low, or if there is lower cranial pulses, then also we electively ventilate the patient. If there are intraoperative VAE or PAE, then it's better to ventilate and observe. Now, if there is also tension pneumocephalus, there will be delayed recovery, and it will hamper the emergence of this patient. That's all. Thank you.
Thank you so much, Dr. Sagar. It was a fairly comprehensive presentation. And I like the fact that you talked about the role of nitrous, whether or not you need it, and also about the PFO screening, because that is something that most people are worried about as to how you would go about. We will take the questions in the end, Dr. Sagar, to stay with us.
Yes.
And I would request the viewers to please put your questions in the chat box so that we can take all of them together at the end. Dr. Bhuwan, may I request you to introduce the next speaker?
Yes, ma'am.
Thank you so much.
Our next speaker is Dr. Priyanka. She is an energetic, enthusiastic professor of Neuroanesthesia and GB Pant Hospital. So she'll be presenting about the neuromonitoring and during posterior fossa surgical procedures. Over to you, Dr. Priyanka.
Dr. Sagar, could you stop your screen sharing so that Dr. Priyanka can start with her presentation? Dr. Priyanka, you would need to unmute yourself.
Yes, ma'am.
Can
Thank
you
you
share your screen?
for
Sure.
your kind introduction and your words of appreciation. I'll just start sharing my screen. So is my screen
Yes,
visible?
yes, we can see it. Yeah.
Bhuwan, can you hear me?
Yes, yes. You can
Hello?
start, Dr. Priyanka.
Is my screen? Okay.
Yes,
yes.
ma'am. We can see your screen and you're audible.
Okay. Thank you so much. So now, after the elucidative talk by Dr. Sagar regarding the anesthetic management of posterior fossa surgery, I would be now discussing mainly about the intraoperative neurophysiological monitoring for posterior fossa surgery. Monitoring is important. It helps us in the assessment of the functional integrity of the neuronal pathways, which gives us a real-time assessment of these pathways and helps in dynamic monitoring of the neural structures within the posterior fossa. So in a way, it is a limited neurological examination, but it is a limited neurological examination under general anesthesia, which can be repeated many times. So IONM preempts neurological insults. What happens during surgery is that there can be either a mechanical injury, which is a direct injury, which can happen due to the surgical steps, or there can be distortion forces, which can be due to the traction by the retractors, or there can be positioning changes. As we all know that posterior fossa surgery can be done in various unique positions, and there can be stretch on the nerve roots, or there can be brachial plexopathy, or excessive flexion of the neck can lead to quadriplegia. There can also be ischemic damage to the neural structures by the stretching of the vascular supply, or maybe sometimes due to the prolonged hypotension, which can happen inadvertently, or if it is demanded by the surgeon in the form of controlled hypotension. So IONM helps all in the in preempting the neuroanesthesiologist and the neurosurgeon regarding the neurological insults which can happen during the surgery. So this is a typical neurosurgical unit. You can see here is the OT table. Here a neurophysiologist is sitting and is monitoring the patient. The surgeon is operating. This is the neuroanesthetist with its workstation and the nursing staff with this scrub nurse and the scrub station. So this is the typical neurophysiological unit, a neuro monitoring machine, I would say, with a screen where you get all the different channels which you opt for during the multimodality monitoring. Usually it is a 32 channel or a 64 channel machine. And here is an amplifier, which is very important. So normally what happens is that from the patient, the signals reach the amplifier. As these are very small, low voltage signals, these are amplified and they then reach the main unit. And from the main unit, you can interpret your signals, and from there, you can actually tell the surgeon or the physiologist whether there is any warning sign or any injury which can happen. So if you look at this picture is not to intimidate you. This is the anatomy of the posterior fossa, but it is just to give you a fair idea that how densely the neural structures are packed within the posterior fossa. And there are various structures, like from cranial nerve nuclei to cranial nerves, which are emitting from the brainstem, to the various sensory and motor pathways, to the various interconnecting neural fascicles. So all these structures are very densely packed within the posterior fossa. Not just that, there can be tumor displacement, which can distort the anatomy and complicate the landmarks, which can further, complicate the life of the neurosurgeon. Also, any damage to these structures, all these are very critical structures. So any damage to these structures may lead to increased surgical morbidity and deteriorated patient outcomes. So the goal of intraoperative neurophysiological monitoring is most important to prevent surgery-induced neurological deficits. And another important goal is that it can also predict the functional outcome. So when we do monitoring, we do it in two forms. Either it can be mapping or monitoring. So when mapping is done, basically mapping is nothing but identification of the neural structures. So it's just like when you map an area, you try and name or identify the places or the structures there. So similarly, in mapping in a neurosurgical field is like mapping or identifying the various neural structures, and it is done intermittently. It is not a continuous thing. While monitoring is the continuous assessment of the neural function, which tests the long neural pathways within the brainstem. So while the surgeon is trying to resect the tumor or resect a lesion, it helps in the assessment of those pathways so that no further injury occurs. So what is the purpose of mapping? Mapping is basically done to identify the safe entry zones into the brainstem. We'll further see how it helps in recognizing these zones. Another important aspect is that it helps in identifying the peripheral cranial motor nerves. It can also help in the identification of the cranial nerve nuclei, which is present within the brainstem, and also the corticospinal tracts, which are present at the level of the cerebral peduncles. So this is a classical example. You see these or an extrinsic lesion, and this one is a tumor. The tumor is just outside, or there is an extrinsic lesion. These are of the tumor itself, because he will approach the tumor and further resect it and further go within. But when the tumor is within the brainstem and there is no external features which are available, then in that case, mapping is very important, as it helps in identifying from where to approach this tumor. Now, mapping includes two modalities. One is the triggered EMG and the other one is brainstem auditory evoked potentials. So if we see triggered EMG is nothing, it's like electromyography, and it is done to look at the electrical activity within the muscle membrane. So cranial nerve EMGs are usually performed in the posterior fossa surgeries, and they are used to monitor all cranial nerves except 2 and 8, as they are the sensory nerves. 2 and 8 are monitored by evoked potentials. However, there is no current monitoring method to look at the cranial nerve 1. And cranial nerve 1 itself is not important for posterior fossa surgery. So usually we look at lower cranial nerves, either it is from 5 to 12, we usually look at all these cranial nerves in the posterior fossa surgery. So what are the probes which are used, stimulation electrodes which are used for monitoring the triggered EMG? They can be either two probes, it can be either monopolar or bipolar. Monopolar probe, as you can see, has just one polarity, either it can be negative or it can be positive. And these four probes, they deliver low intensity stimuli which has a wider current spread. So you can easily localize the nerves, but there is one disadvantage, that this current leakage can happen. So in those areas where you have to selectively stimulate, very selectively stimulate, you tend to use bipolar probes, where within the probe you have both positive and negative polarity, and there the leakage of current is limited. The stimulation parameters which are used for triggered EMG are, it is usually a rectangular pulse with a frequency of 1 to 3 hertz and intensity of less than 5 milliamperes. It is usually less than 2 milliampere intensity, which is usually used to identify various structures. More than 2 milliampere intensity is usually used for response in the tumor tissue. The recording method is usually by the help of surface needle electrodes or the electrodes which are placed subdermally over the muscle. So for various cranial nerves, we have different muscles in which the electrodes are placed. For cranial nerve 3, usually it is placed in the inferior rectus and inferior oblique, as you can see here. And for the cranial nerve 4, it is usually placed in the superior oblique muscle. For cranial nerve 6, it is usually placed in the lateral rectus muscles. Now, because they are placed so close to the eyeball, they have to be placed very cautiously. Cranial nerve fifth has three divisions. The ophthalmic and the maxillary division are the sensory division. The mandibular division is both mixed sensory and motor. The motor component actually innervates the muscles of the mastication. So obviously we need. So I've already spoken about cranial nerve 7. Now the cranial nerve, glossopharyngeal nerve can be also recorded by the insertion of the electrode in the stylopharyngeus muscle. This is the most difficult location of putting the electrode. Nonetheless, it is very important because it is very important to monitor the lower cranial nerve, especially 9th and 10th. For 10th or the vagus, either a wired endotracheal tube can be used, which is the NIMS tube, which is also called the neural integrity monitor tube, which has the electrodes within the wall of the tube, or you can use an insulated or regular nerve needles, which can be placed into the cricothyroid muscle. Hypoglossal nerve can be monitored by insertion of the electrodes within the tongue muscles. And the 11th nerve can be monitored by placing the electrode in the trapezius muscle. So once the electrodes have been placed and the stimulus has been given, we get a response. To understand the physiology of response, we should understand what is a motor unit. A single motor neuron and the muscle fiber it innervates constitutes a motor unit. And whenever the trigger is given or a stimulus is given, the muscle fiber contracts in response and generates an action potential. When all the fibers contract, it is called a motor unit action potential. When the motor unit action potential is generated from a nerve trunk, that is numerous axons, then in that case, it is called as compound motor action potential. So this is a diagram where you can, this is the graph where you can see the electromyogram from the orbicularis oris muscle. And here again, you can see this again a waveform where you can see that the muscle action potential has been generated from the orbicularis, from the 7th cranial nerve, and there has been some amount of waveform generation at the 5th cranial nerve because it was very close to the 7th one, and so that is why some amount of muscle action potential is also there. And this is the stacked electromyogram, which you can see here. Again, there are muscle action potentials generated when the stimulus or the trigger was given. This is a waveform, and the picture showing this was a tumor which was present within the pons, and at the floor of the 4th ventricle, when stimulus was given, the waveform was generated at the level of the right orbicularis oris muscle. So that is how the facial nerve nucleus was identified when the surgeon tried to enter into this brainstem tumor. This is another case which shows the importance of triggered EMG. In this case also, as you can see in the sagittal view as well as in the coronal, and so as you can see that the facial colliculi are usually present in the upper zone of the floor of the 4th ventricle. And when the surgeon tried to stimulate these areas, he got the response at a higher current. But when they tried to stimulate in the lower zones, they found that the response was seen at 0.2 milliampere, that is at a much lower current, which means that the facial colliculi were here, much lower. So the incision was made accordingly and the tumor was resected. And as you can see in the postoperative MRI, the tumor was completely resected and the patient had no neurological deficits. So this is the importance of mapping. Another important technique for mapping is brainstem auditory evoked responses, and this is obviously seen in the vestibulocochlear nerve, which is a sensory nerve, and it measures the neural response of the auditory system to the sound stimulation. They are repeated and the electrode is made secure. The response which is generated is usually seen at the level of, as you can see, it is for monitoring the response, the electrodes are placed at the level of the CZ or at the level of the higher forehead frontal polar zone. The other two electrodes are placed at A1 and A2 areas along the right and left ear over the mastoids, and a ground electrode is placed in the posterior part of the forehead. So what is the auditory pathway? So to understand how the brainstem auditory evoked potentials are generated, we need to understand the pathway. The pathway is usually from the cochlea. From the cochlea, it goes through the it goes into the cochlear nuclei, and from the cochlear nucleus, it reaches the superior olivary nucleus in the pons, and from there it reaches the inferior colliculus and into the medial geniculate body, and from there it goes into the auditory cortex. So this is the path. The common mnemonic used to remember this pathway is E. colima, and these various nerves through this pathway. The first wave, out of which usually first 5 waves are considered to be important. 7 waves are generated, out of which first 5 waves are considered to be important, out of which first, third, and fifth are considered to be the most important. Wave is usually from the
Ma'am, I would like to request you, ma'am, if you can join with a good network bandwidth, ma'am.
out of which contraction directly on the auditory nerve can cause a change in the signal. A thermal injury due to electric coagulation near the nerve can also cause change in the signal, or there can be some vascular injury near the internal auditory artery, which can cause the change in the signal. So the criteria for warning are there can be 50% drop in the amplitude, or a change in or increase in the latency by 1 millisecond is considered to be a warning sign. Now changes, as I 1 and 3 are very important, and side change in fifth can also be considered important. So if there is a loss or delay of first wave, which means the proximal wave has been proximal part of the auditory pathway itself has been damaged, and there is cochlear dysfunction, and that is why we are not getting either first wave or any of the subsequent waves. For if the wave 1 is preserved, but there is loss of wave 3 and 5, that means there is compromise of the proximal 8th nerve or in the pontine area. For posterior fossa surgeries, this latency between the wave 3rd and 5th are very important, because this is the area from which the auditory pathway transmits the signals from within the brainstem, that is from the neural structures. Here, you don't have to evoke any potential or give any stimulus. It is purely an observation of the muscle spontaneous activity. The electrodes are used similar to what we use for triggered EMG, and the response which is generated is the spontaneous scene maps, which you can see on the neuromonitor screen. So what are the responses that we see with the free EMG? The healthy normal nerve root can be seen as a small sustained activity on the as a small sustained waveform activity on the screen. There can be popcorn EMG discharges, which is just like a simple contact with the nerve, kind of waveforms, but also audible signals are also seen on the or also can be heard by the neurophysiologist and also by the surgeon. So when the surgeon hears some kind of popcorn discharges, they get to know that they're very close to the nerve, but the damage has still not occurred. However, when there is some kind of strong neurotonic discharges, like this kind of burst discharges, that means there has been strong contact with the nerve with some amount of damage, a kind of reversible damage which has occurred and which has led to these neurotonic discharges. However, when the discharges are like burst kind of activity with very high intensity and high amplitude, then that means with trains of activity, which means that the surgeon probably has inadvertently or somehow there has been some damage to the neurological structure, and you can actually predict a little worse outcome when you get these kind of discharges. So let's come to the somatosensory evoked potential. The somatosensory evoked potentials is, as the name suggests, it tests the sensory pathway or the ascending pathway. So the stimulus is given at the level of the peripheral nerves, and the response is seen at the level of the cortex. start from the upper limb or the lower limb. The upper limb is usually the nucleus cuneatus, the fasciculus cuneatus, and the lower limb is the fasciculus gracilis. And these responses, then they ascend and reach the nucleus cuneatus and corresponding nucleus cuneatus and nucleus gracilis in the brainstem. There they decussate in the medulla oblongata and reach up to the two centimeter proximal to the wrist crease. You apply the electrodes for the tibial nerve. Usually 1 to 2 centimeters distal and posterior to the medial malleolus, the electrodes are applied. The recording of these evoked potentials is usually done by, first of all, the stimulation is done. The rate is 2 to 4 hertz. Duration is 0.2 to 2 milliseconds. Frequency of 100 to 500 repetitions are usually done, and a fixed filter of 10 to 1000 hertz. So where are these responses recorded? The responses are recorded in the cortical area, as I told you, and usually in the somatosensory cortical area, which corresponds to CP4 and CP3 areas within on the scalp. And this is basically based on the 1020 EG system, as you can understand. And usually the line from the mastoid, joining the two mastoids, you can, from the midline, little to the midline, you can see the CP3 and CP4 pointers or the locations where the electrodes are placed, and a ground electrode is placed on the neck, and one of the electrodes is also placed on the cervical vertebra to look at the cervical spine. So wherever the electrodes are placed, you get some kind of waveform. So N9 waveform is usually seen at the Erb's point where the electrode is commonly placed. N13 is again another response in the waveform, which is seen at the level of the cervical level. And N20 is seen at the somatosensory cortical area over the scalp. So these three are the important waveforms. When you see the somatosensory evoked potential, these three are the important waveforms that are to be monitored, and the latency in these waveforms are important for us to understand whether there is any sign of injury to the sensory pathways. Repeated stimulations are given to look at the neural tract and any impending neural the normal response is usually when we look at N9 to P14, it represents the time from the conduction between the brachial plexus and the cervical spine. As I told you, N9 is over the Erb's point, and N13 or N14 is over the cervical area or cervicomedullary junction. So the latency is between N9 to P14 tells us the pathway from this area to the cervical spine. From cervical spine to the somatosensory cortex, it is the latency between the N13 to N20, which is also called as the brain conduction time. So this is again very important.
Bhuwan, can we interact with you in the meantime while we are
Yes,
trying
ma'am.
to get
Yes,
ma'am to missing this, and Sagar. Sagar is also there. You were asking a question to Sagar, no?
Yes, he has answered actually.
He's answered that.
Yeah.
Sagar, you've talked about transesophageal echocardiography. Are you there, Sagar? Yes.
Yes.
This is not available at all centers, right? So you can't expect all centers to be using a T, although it's a highly sensitive modality, and you do have grading of, how severe this thing is. So what is a practical option?
Ma'am, the most convenient one is ETCO2, what we have. And even precordial Doppler also, if we have, it will be difficult to position in such patients. It will be a difficult one to keep it in the third and fourth stage of intercostal stage. So the most feasible one we have is ETCO2 only here. But it's again non-specific for VAE. So, and it's a semi-quantitative one, so we have to be very vigilant.
Yeah, I think vigilance and a combination of ETCO2 takes care in most cases.
Yes,
most cases, if you're early to catch it, and if you're early to warn the surgeon and switch off your nitrous if it is on, switch to 100% oxygen, and importantly, tell the surgeon to flood the area with saline and cover it with the gauze. prevent further entrainment. That's important. Severe pulmonary embolism, severe venous embolism. Would you want to tell us something about that? Massive venous embolism.
Massive embolism, like volume more than 5 ml per kg, it may happen. And then it's a massive embolism. It also depends upon the rate of the entry. The rate of the entry is very fast. Symptoms may appear all of a sudden, and there may be right ventricular outflow obstruction, which will further causes cardiovascular collapse, immediate cardiovascular collapse in such patients. And what we can do is we can initiate a cardiac message also in such patients, so that if the airlock can be broken, it will break into small microfibrils.
I think Dr. Priyanka has
Yes.
rejoined. So we'll continue after the listening. Yeah.
I'm so sorry. So motor evoked potentials, why are they important in posterior fossa surgery? It is important. Why? Because these fibers, the corticospinal fibers, are basically densely packed in the midbrain area and in the form of cerebral peduncles, and then they decussate in the medullary area. And so sometimes whenever there are locations when the tumor is within these areas, then it is very, very important for us to monitor these MEPs. So another important aspect is that we need not monitor many muscle areas. Why? Because since they are densely packed, so selective injury is not possible. So we can easily monitor one muscle fiber, one muscle in the upper limb and one in the lower limb. The electrodes which are used for MEPs are the corkscrew electrodes, which are placed on the scalp. And the scalp area which is usually monitored is over the motor cortical area. It is from C3, either from montage, which is used as either from C3 to C4 or C1 to C2, which overlies the motor cortical area over the scalp. Again, this is according to the 1020 system that we use these electrodes and place this on the particular cortical area, whichever we want to monitor. For the motor, we use it as C3, C4, and C1, C2. For sensory, as I told you before, we use either CP3, CP4, or CP3, CPZ, or CPZ, CP4 montages. So again, for MEPs, we use C3, C4, and C1, C2 montages to monitor the motor cortical area. So once the electrodes have been placed, the stimulation is done. And these are the stimulation parameters which are usually used for monitoring the MEPs. The electrodes, the recording electrodes are placed in the muscles. For upper limb, usually abductor pollicis brevis or abductor digiti minimi are used. For lower limb, either abductor hallucis, gastrocnemius, or tibialis anterior are usually used. So as I told you, for posterior fossa surgery, we need not use recording electrodes in different muscles. We can use only one muscle in the upper limb and one in the lower limb. So different waveforms are generated at different levels in the MEPs, but we usually, since in posterior fossa surgeries, we usually use the muscle MEPs or myogenic MEPs. So the muscle, the waveform which is generated is equivalent to CMAP, which as we had already seen in the EMG waveform, which is similar to EMG waveform. The common alarm criteria which is used, is either a complete signal loss, or there is an amplitude reduction, or a threshold elevation happens. Threshold elevation means that there is an increase in the electrical stimulus which is required by the surgeon to generate the same amount of response. So when there is complete signal loss, obviously MEPs are very sensitive potentials. If there's a complete signal loss, so that means this, it's a big warning sign. If, however, there is an amplitude reduction, and the amplitude reduction, different thresholds are used by different people. Usually a reduction threshold of 70% is considered. Sometimes some people also consider threshold reduction of 50%. And also, if the amount of electrical stimulus required is increased, requirement of the electrical stimulation is increased. And also there was for the pilocytic astrocytoma within the midbrain, as you can see, it is right here at the level of the cerebral peduncle. So the surgeons wanted to approach this tumor, and when they did the MEPs, they found that the potentials which were generated was only seen in the left area. This was in the left cerebral peduncle, and the MEPs which were generated were seen in the ipsilateral limb, but the contralateral, probably because of these peduncles, the contralateral MEPs were not seen, and the response was not visible. So they approached the tumor from another location, probably from the lateral aspect, and they could, remove the tumor, as you can see in the post-operative picture, and with no neurological deficits in the patient. So this was all about mapping and monitoring. Now let us look into the anesthetic considerations for use of intraoperative neurophysiological monitoring. We know that for intraoperative neurophysiological monitoring, the teamwork and the communication between a neuroanesthetist, between a neurosurgeon, and a nurse and a neurophysiologist is very, very important for the success of getting these signals, and also for the success of the outcome of the patient. So several physiological conditions can also impact the IONM, out of which systemic hypertension is very, very important. Any hypertension which occurs, sudden hypertension which occurs during the course of surgery may deteriorate your signal. However, when you improve your mean arterial pressure, this deterioration of signals may improve, and you may get proper signals again. Hypoxia and hypercapnia may again impair the neural function, so it is very important to maintain the oxygenation and the CO2 status of the patient. Temperature hypothermia can delay neural conduction and can cause increase in the latency. However, moderate hypothermia can still be used without much harm to the signals during the neurophysiological monitoring. The anesthetic agents can have a huge impact on the neurophysiological monitoring, and that is why the role of neuroanesthetist is very, very important when this multimodality monitoring is being used. Now, why anesthetic agents have an impact is because all this monitoring is based on the synaptic transfer of the signals, and the multiple pathways that are usually monitored have synapses, and all the anesthetic agents which are used have they basically alter the synaptic function. So because of their effect on the synapses, the anesthetic agents have a huge impact on the neurophysiological signals. Also, secondary pathways can suppress or enhance the primary pathways, and the anesthetic agents have impact on the secondary pathways. Then they have global effect on the cortical and spinal cord neural processing, again leading to some effects on the signals. Obviously, neuromuscular agents, they block the neuromuscular junction, and hence any kind of myogenic stimulus, the myogenic response cannot be monitored when we are doing neurophysiological monitoring if we use neuromuscular agents. So let us look into the individual anesthetic drugs which can affect these signals or potentials. The inhalational agents, especially all the halogenated inhalational agents, have profound effect on the cortical responses. However, for MEPs, the epidural D waves have minimal changes, but they can abolish the CMAP and MEP even at very, very low doses. So inhalation agents especially have a huge impact on the MEPs. They also have effect on SSEPs, but the effect of SSEPs is on higher doses. But with SSEPs, you can usually use the MAC dose of these inhalation agents less than 0.5. But generally, we tend to avoid inhalational agents when we are using neurophysiological monitoring in our patients. As I already told you, the transcranial MEPs are enormously affected by the use of inhalational agents. As you can see, before isoflurane, you were getting very, very good signals. With the use of even 0.5% isoflurane, the signals were totally gone and they were abolished. And the main impact was basically on the anterior motor horn cells. And here, the inhalation agents also affect. And because of this, the MEP signals were absolutely not seen. If we look at the effect of halogenated agents on brainstem auditory evoked potentials, they are little, I would say, not affected by these agents, and they are more rigid and less prone to the effect of these agents. So you can still consider using halogenated agents when you are just doing auditory evoked potential. But here we need to consider that usually these modalities are done in a multimodal manner. So it's not that you are usually using only auditory evoked potential. With auditory evoked potentials, probably you would be using other modalities like triggered EMG or your cranial nerve nuclei, and also spontaneous EMGs or maybe MEPs. So in that case, it is always better still not to use inhalational agents. Now, looking at the effect of IV agents, propofol, obviously they depress the cortical response, have lesser effect on the subcortical response. Ketamine, they can increase the cortical SSEPs and MEPs, and so they are sometimes used when you do not get signals or when the signals are of very, very low voltage. Dexmedetomidine has minimal effect. So dexmedetomidine is commonly used as an adjuvant in patients who are monitored for these neurophysiological signals, and it is a part of TIVA technique very commonly used. If we look at the effect of muscle relaxants, then these muscle relaxants, they impair MEP and EMG monitoring as they obviously block the neuromuscular junctions. However, with the partial neuromuscular blockade, EMGs have still been reported to be used. But still, it is better to avoid the use of muscle relaxants if you are considering the use of MEPs and EMGs. So the recommendation is to prefer TIVA for optimal MEP monitoring as well as other multimodal monitoring, and avoid neuromuscular blocking agents whenever you are using MEP and EMGs. So when we look at the effect of these drugs on SSEPs, BAEPs, and MEPs, so what we see is that most of the opioids, alpha-2 agonists, ketamine, etomidate, they do not have any effect on these evoked potentials. So they can be used very easily, and they should be used as much as possible to avoid and spare the usage of other anesthetic agents. So if you see the halogenated anesthetic agents, including the nitrous oxide, it has huge impact on SSEPs and MEPs. And however, brainstem auditory evoked potentials are more resistant to the effect of these anesthetic agents. So for SSEPs, if you are considering, then in that case, NMBs, if only SSEPs are being used, then NMB can be used with them, because if it is the sole monitor. However, if it is used as a part of multimodal technique, then obviously you need to avoid your neuromuscular blockade. Inhalation agents can obscure the potentials. Up to 0.5 Mac may be used, but it should still be avoided. For opioids, they do not have significant effect, but yes, you need to avoid any bolus or very, very high dose of opioids. TIVA is ideal, but avoid very high infusion rates or any boluses, and you need to maintain a constant plane of anesthesia. For transcranial MEPs, as I told you, NMBs cannot be used. Inhalation agents have a huge impact. They cannot be used. Nitrous oxide should also be completely avoided in case of transcranial MEPs. Opioids do not have a significant effect again, but boluses should be avoided, and TIVA is the ideal technique again, but bolus has to be avoided. For electromyography, NMBs cannot be used. Inhalational agents do not have a very significant impact, but should again be avoided, as TIVA is again the ideal modality. Again, you do not use boluses, and if you really need to use bolus, it is better to use a benzodiazepine bolus as compared to the bolus of propofol. Opioids do not have significant impact and can be easily used. Now, suppose there is a signal loss during the surgery. What will be your considerations when you look at the signal loss? So there can be multiple factors. There can be the first most obvious impact could be the surgical factor. Then there could be some kind of anesthetic problems which may have an impact on the signals or the potentials that we are trying to look at. There can be some kind of mechanical glitch, like something like which happened with me right now. And this can also lead to the loss of the signals. So what is the checklist when you get a loss of signals? What has to be done when we see that there is some kind of decrease in the amplitude or maybe increase in the latencies or a complete loss of signals? In that case, the neurophysiologist has to take over. He has to inform the surgeon. The surgeon pauses the surgery for some time. Until that time, the neurophysiologist, he tries to repeat his test. He checks his electrodes and connections. There can be some loose connections. He tries to confirm his impedance of various electrodes and looks at whether there has been some change somewhere which has led to the mechanical response, mechanical assessment of the response. And then obviously he has to inform the anesthesiologist. The anesthesiologist has a huge role here. They have to ensure that there has been no bolus drug administration. They have to check whether there was some neuromuscular blockade which was given or not, or some inadvertent kind of fall in the mean arterial pressure or hypotension, which has occurred maybe because of the sudden blood loss, or there can be hypercarbia or hypoxia, which can cause the change in the stimulus. So all that has to be seen by the anesthetist, and they have to maintain the homeostasis of the patient. Now then comes the role of the neurosurgeon. If all this is in place, the neurophysiologist has confirmed that everything is in place, anesthetist has confirmed that the patient is absolutely fine and the vitals are all stable and the physiological condition is all fine, then the neurosurgeon has to obviously see and look at whether there has been some traction on the nerve or the neural structure, or he may have to suspend a surgical procedure, or he may have to change the approach, as we had seen in the previous examples that they changed their approach and they could completely remove the tumor and also get the proper surgical outcome. And sometimes papaverine is also given to dilate the vessel if there is some kind of ischemic injury which is happening. So as now you can understand that a change in the signal affects everyone. So the teamwork is very, very important. Everyone has to communicate with each other and to tell their findings and be at the same page so as to understand what was the cause of the change of the potentials, and so that we get a proper outcome and the success of the monitoring. So in summary, the primary goal of IONM during neurosurgery is to prevent neurological injury. Initial mapping is done to identify critical structures in the posterior fossa. The mapping techniques usually used are the triggered EMG and the brainstem auditory evoked potentials. The monitoring is done usually for continuous neural assessment of the neural structures. The monitoring techniques which are used are free EMG, SSEPs, and MEPs. We use usually the combination of modalities to allow the real-time detection of these neurological structures. And when the changes occur, they can be reversed or minimized if corrective measures are taken in time. And if these corrective measures are taken in time, they help in improving the surgical outcome. And as I told you before, effective communication between the neurophysiologist, surgeon, and neuroanesthesiologist is completely essential for the successful intraoperative neurophysiological monitoring. So thank you so much, and I'm so sorry for all the technical glitches which kept happening again and again during the small talk. I apologize for that.
No, it's all right. Thank you very much, Dr. Priyanka, for an excellent and eloquent talk. There's one question in the chat box. Can we use etomidate infusion instead of propofol infusion during monitoring?
Etomidate can be used, and in fact, it helps in the improvement in the signal, the evoked potentials. But since etomidate, TIVA with etomidate is quite difficult. I mean, because you need to maintain a plane of anesthesia, and your controlled infusion pumps with etomidate, it is not a very common technique to be used. Etomidate is sometimes used when you do not get signals. It can be used there to improve the quality of the signals when you are not getting them. So as an infusion, as a TIVA, I don't think so. It is a very, very logical thing to use. But yes, TIVA with propofol and etomidate very rarely sometimes can be used to improve the signal quality when you are not getting proper potentials.
So what are the drugs you are using during SSEP or MEP monitoring?
We are usually continuing with TIVA, that is propofol, but as we do not have remifentanil right now with us, so we use propofol with fentanyl, and we use neuromuscular blockade at the time of induction, but and we use a TOF monitor. So once the effect of neuromuscular blockade goes away, we stop using further neuromuscular blockade. We don't use any boluses or intermittent or infusions, and we just keep the patient on TIVA with fentanyl infusion, with like both propofol and fentanyl infusion. And obviously we do the depth of anesthesia monitoring with these patients. So deeper depth of anesthesia is obviously required if you are using neurophysiological monitoring.
So do you use BIS monitoring in all the patients?
Yes. We do use BIS monitor for all the patients.
So what is the level of that BIS numbers?
We usually go for the same level, 40 to 50, and try to maintain a continuous plane, a little deeper plane of anesthesia, so that we do not have this thing. We do not have with the avoidance of use of neuromuscular blockade. We do not have much problem. Also, we usually use dexmedetomidine with the TIVA. as an adjuvant. So with the use of dexmedetomidine, propofol, and fentanyl, we get an adequate pain of anesthesia. And usually we keep a BIS of 40 to 50. With dexmedetomidine, there's one problem that BIS may not be very reliable. So in that case, we usually use SEF. We look at SEF. So SEF is a more reliable marker for dexmedetomidine. So we usually keep a SEF of 12 to 16, and which almost corresponds to the BIS value of 40 to 50. And this we maintain throughout the surgery. And as I told you, neuromuscular blockade is given at the time of induction. After that, we stop using neuromuscular blockade. So when the physiological monitoring is done, a baseline stimulus is baseline potentials they get. And then over those baseline potentials, they keep looking at further potentials, and any change in the latency or amplitude is then obviously notified to the anesthesiologist or the surgeon. Something is happening.
Two more questions. What is the infusion dose of etomidate by Dr. Muthukumar? But actually, yeah.
I couldn't get your question.
What is the infusion dose of etomidate?
Infusion dose of etomidate, I do not use etomidate.
Normally, it is propofol only.
So I'm not well aware of the But yes, obviously we can look into the literature and see whether how much at what dose etomidate can be given. But I think it is still not very popular to use etomidate. It is the popular modality used is for T-wise propofol with fentanyl and adjuvant as dexmedetomidine.
And there is one more point, like BIS is very much corresponding with the propofol. And that's why with BIS, it is better to use propofol.
Yeah,
exactly, there's one more question actually. Opinion on ketamine and dexam combination by Dr. Manikandan.
Dexam and ketamine.
Yeah.
Again, the problem with dexam and ketamine can be used, and but using only ketamine is not a very great idea. It can be used with propofol, and in our setup, we have been using ketofol for certain surgeries. Ketofol combination can be used, like 1:3 of ketamine and propofol can be used together. And with that, obviously, dexmedetomidine can be added on. But again, the problem is that this is not a very good number to monitor when you're using ketofol and dexam. Again, when in that case, if you have to monitor the depth of anesthesia, then maybe you can use spectral H frequency. But yes, ketamine alone, not. But yes, ketofol can be given, and maybe dexmed can be used as an adjuvant with that.
It's just like using liquid oxygen.
Liquid oxygen.
A little bit of a comment out here. Dr. Muthukumar, somehow as neuroanesthetists, we are not very fond of etomidate as a drug. One is the adrenal suppression, and second is the epileptogenic potential. Although infratentorial tumors have a lesser risk of seizures, but this is one drug which is probably not a very popular drug with neuroanesthetists. And ketofol we've been using, and we found that it provides greater hemodynamic stability as compared to the use of propofol alone. And you could use it in a ratio of 1:3 or 1:4, which gives a nice balance of hemodynamic stability without and you also avoid the other side effects of that extreme tachycardia with ketamine and all that stuff. And another point is, yes, when we use ketofol, we switch to spectral edge frequency. This, of course, is not a very good indicator of that, and we tend to keep a higher SEF, somewhere around 18 to 20, because BIS itself is not a very good indicator. Dr. Manikandan, Ketodex can be tried. Have you used it? It's not a bad option.
Sir, question is from Momita only, through Momita in chat box.
So we can't hear. We can't hear. Right. I think this INOM it was a good addition to this entire discipline, because most of it, now this is becoming increasingly more and more relevant. INOM is almost, I think, in the past few years, although the evidence is still gathering, evidence becomes strong only when you have more and more studies coming in. So probably a few years down the line, we would have a much stronger evidence in favors. At this point of time, what's your opinion, Priyanka? What is the evidence in do we have any evidence in the favor or this thing of INM?
Evidence, yes, ma'am. There have been certain articles, like some retrospective analysis and review analysis of their own institutional experiences, and they have shown various centers, which have been using IONM for last 20 years, 15 years, like that for a very, very long time. They have shown that even in thousands of surgeries, when they've used it, and they have found that the impact is quite good in the sense that they have been able to reduce their neurological morbidities, the outcomes have improved, and the patient post-operative patient dependence, all that has decreased with the use of intraoperative neurophysiological monitoring. So although I would say that it is quite costly, it is labor intensive, it requires a lot of experts, the time required for surgery obviously gets increased when we use IONM, but it is worth worth it, because the outcome obviously is improved, and not only that, that it is able to identify the neuronal structures which can get damaged during the surgery. The another important point is that the surgeon gets the confidence of meticulously planning the surgery and conducting it, and there is the improvement in the chance of the complete removal of the lesion or the tumor with the use of IONM, because they are quite confident that they are not damaging any neural structures, and they are thus able to improve their resection. So anyways, it has a huge impact on the clinical outcome, and now it is almost a routine practice to use IONM wherever it is indicated, obviously not in all cases, wherever it is indicated. And most of the neuro centers are using IONM on a routine basis, very commonly.
I think, this is kind of, in a way, representing the evolution of neuroanesthesia and neurosurgery. Way back when I had joined as an SR in early 1990s, we used to rely only on cardiovascular parameters to tell us that there is a possible neural injury occurring. Then we also had a few case reports, where they tried to use respiratory monitoring. The patient was put on spontaneous respiration or pressure support ventilation as an indirect indicator of a potential neurological injury. A little bit of an adventure at that point of time. But now with IONM coming, see, as I told you at the beginning of the lecture, you have very, very critical neural structures out here. And a little bit of a damage can have devastating consequences. And especially, in tumors like brainstem gliomas or acoustic neuromas, where the nerves are so, the cranial nerves are so close by and they're so intertwined. So for a surgeon to be able to get that confidence, with the mapping that, fine, I have a very good, safe entry zone to enter, and I'm not, causing damage to any structure, and I'm not damaging the facial nerve. He will do this handheld monitor and repeatedly look, trigger, and see whether or not. It really helps the surgeon, in finding a safe zone and preventing an iatrogenic injury. Remember, at the end of the day, the goal of the neurosurgeon is to remove as much as possible and safely. So probably evidence is going to build as more and more reports come in. A lack of evidence doesn't mean that a thing is good or bad. We probably have to wait for a few more years for more definite guidelines as such to come. But till that time, on a practical basis, we are telling that almost all centers which have it are using it, and surgeons are feeling much more comfortable with IONM monitoring. Would you agree, Priyanka, there?
Totally, ma'am. Totally. I agree totally with you. And as you must have also seen that even in our center, we have of late started using it very, very frequently. And we have realized that with the use of IONM, we have been able to prevent damages and neuronal injuries, and the postoperative outcome has improved. The surgeons have become more careful in doing their surgery, and they are able to remove the tumor, I would say more completely or near completely with the use of IONM.
So definitely evidence in terms of prevention of an injury. On neurological outcomes, probably we'll have to wait a few more years for better evidence for this. But yes, unless we use it, we will not be able to gather enough evidence to come up with a guideline. Any other questions in the chat box, Bhuwan?
No, ma'am. No other questions.
Jayashree, ma'am, would you like to add something to it?
No, I just wanted to say, Nanika, that we are also using routinely intraoperative neuromonitoring for the spine surgery. So our spine surgeon is very fond of it. And so now they are very comfortable. Bhuwan will vouch for that. And they are doing that regularly. I think they have started for posterior fossa, but spine is a routine. So definitely new modalities are there. And we, at least the people who have these facilities and can afford to have them, should use them.
When 2 days back, only one case was there, which was close to, the tumor was close to brainstem, and they were confused whether it is a nerve or vessel. Then they tested with the stimulus. They found it is not a vessel actually, it is a nerve. So they changed the plan. So this is very important.
Yes.
It's a very deep structure and it's difficult to see or assess.
Right.
Yes. Bhuwan, there's another question there.
Yes, ma'am. Yes. When we give mannitol, it leads to huge diuresis. It's not coming fully.
How are we supposed to calculate?
How are we supposed to calculate fluid and
Calculate
transfuse
fluid.
considering that loss?
Yeah.
From Dr. Jyoti, yeah.
I think either of you can answer this question, Priyanka or Sagar.
Dr. Sagar, if you can.
Is Sagar there?
I think with the use of mannitol, obviously, whenever there is diuresis, we take into account that urine output, and obviously we have to maintain the intravascular status, and the fluids are given in accordance with the increase in the output, because the purpose of mannitol is to get the hyperosmolarity in the interstitial fluid, so that there is this brain edema which is happening is definitely reduced with the use of mannitol because of its osmotic pathway. Now that doesn't mean that the intravascular deficit has to be done. The intravascular volume status has to be maintained, and for that we have to obviously compensate for that excess urinary loss which is happening with the mannitol. And this has to be done not just by the calculation of the urine output, it can be done by various methods, like by using not just the vital parameters, but also our various fluid responsive parameters, which includes your pulse pressure variation and stroke volume variation, which you can very well use on your regular monitors. So pulse pressure variation is very common parameter that we use. CVP is a very static parameter, which is not very reliable. So pulse pressure variation is one parameter which we use very often to look at the intravascular status, and definitely we compensate for whatever the losses which is happening due to increased diuresis because of the mannitol. But not just the actual losses, we have to look into we try to monitor the intravascular status. And the use of ultrasound is also very good, because what I feel ultrasound is a boon with neurosurgical cases is because your abdomen is absolutely free. Abdomen and thorax is very much freely available to you because the surgical field is at the level of the brain. So you can look into the IVC also to see the intravascular status. Even while the surgery is being done, you can put your probe within the drape and look into the IVC.
Jyoti, one small point for you. Do not think of mannitol if the patient is in a sitting position. We do not use mannitol. We are using sitting position. That takes care of, that's the primary reason why you use it. And if you give mannitol in a patient in sitting, you will be struggling with the fluid, because even, the CVP is usually on the negative side. If you are monitoring the CVP at this thing, if the patient is being done in the lateral position or in the, the lateral or supine with head turn, then of course one can, consider it. There's another question by Dr. Manikandan, which is about the role of Xylocard in keeping the adequate depth without letting the patient to buck. Either of you could answer this. Am I audible?
Yes, ma'am. Adequate depth.
Xylocard, yeah.
Depth, Xylocard would not affect actually the depth of anesthesia, but yes, obviously it will improve the tube tolerance, and the extubation response can be curtailed. And yes, it can be used, but usually we use it at the time of extubation. I'm not exactly able to understand.
But since this is a sodium channel blocker, it will affect the depth actually. It will reduce the depth. Rather, it will be a rather deeper plane of anesthesia than
it can also cause delayed recovery also.
That's true.
Delayed emergence may be there if we use continuous infusion of Xylocard intraoperative.
Because it will be a deeper plane.
Actually, xylocaine is now increasingly being considered as a part of a multimodal analgesia technique. So people are tending to use it, one. And secondly, How many of your patients do you extubate on table? What is the policy? Do you extubate them on table? Is it a slightly delayed elective ventilation? What is the practice?
Most of the posterior fossa surgeries are planned for elective ventilation only in post.
Yeah, just let the, take the patient to the ICU, and when the anesthetic
Yes.
effect wears off,
Anesthetic
or
wears
where
off.
primary CT has been done, then you would consider.
Yes.
But Xylocat has been used, yeah. I mean, you can use it, keeping
In
all
our
the
setup,
caveats in mind, yeah.
in our setup, we mostly use to blunt the hypertensive responses only as a bolus. Infusion we are hardly using, but it
Yeah.
can be used, but it may delay the emergence because of the prolonged effect of the xylocardium.
True.
As a bolus, one could consider.
As a bolus, we can consider.
So N2O, that is nitrous and mannitol, should be avoided, and preloading should be done in an adequate way. Otherwise, there will be too much of hypertension or hyperperfusion. So these two things I think are very important for this.
And if you're using MEPs, then it's very important to put in a soft mouth gag. Otherwise, injury can
Right.
occur.
Yes.
True.
Should we call it a day, ma'am?
Yes, we've had such a good interactive session. Thank you so much. This was a lovely webinar, so much of interaction, so many questions which were answered by all the experienced moderators and, of course, the speakers. Very important topic for the students and for the neuroanesthesiologists. Thank you so much, Monica. Thanks a lot, Bhuwan. And thank you, Dr. Sagar and Priyanka, for those lovely lectures.
It was a
Very
privilege,
important
ma'am.
topics.
For giving us the opportunity.
Yes.
Thank you.
Thanks.
Privilege.
Thank
And a huge thank you for Dr. Manikandan for joining us. Dr. Manikandan is now the director at Sri Chitra, and for him to come and join the session, it means
Wow,
us. Thank you so
that,
much.
that means a lot. Thank you so
That
much,
means a
Dr.
lot to us.
Manikandan. And thank you, Vineet, Roma, and Monica.
Thank you so much, ma'am.
Momita.
Thank you,
Thank you so
Momita. Thank you,
much.
Momita, and Dr.
Thank you,
Sanish
ma'am.
and Saloni.
Thank you.
Thank you.
Thank you so much
Thank
to
you,
all
Good
of
Dr.
you.
night.
Manikandan.
And
Good night.
with all due permission, I'm closing